Assalamu alaikum. Thank you very much, dear friend Dr. Hatem, for your kind introduction. It gives me a great honor and privilege today to be with you in this highly prestigious meeting and to share with you about our LVAD experience First of all, I would like to give a brief introduction about our center. It is a self-operating entity. It's a governmental hospital which cover 24/7 cardiac services for adult and pediatric cardiology and wide range of cardiac surgery procedures. The center receives patients by referral from different hospitals. So Al-Hassa, it is the major and the largest province in Saudi Arabia, which is located in the east of Saudi Arabia. It covers a quarter distance of the total surface of Saudi Arabia with around 1.3 million population. It has become the first Gulf city to be chosen by UNESCO as a creativity city in 2016. Although it has been chosen by the World Heritage by UNESCO also last year. Heart failure is a complex syndrome with heterogeneous clinical manifestations and with diverse of etiology. It's a global epidemic, and it represents 30 million people on the globe who are living with heart failure. Despite the huge burden of heart failure on the society, yet awareness of the disease is dangerously low, and which led to a result of many premature deaths. Heart failure, as we mentioned, it's deadly and costly. In-hospital mortality range from 13.6% in the first year of the diagnosis and 40% in 5 years, and 55% of the patient readmitted in 6 months. Currently, the cost of heart failure has skyrocketed, and it's going to be doubled in 2030. So the optimal treatment for heart failure with regards to the mortality remains unknown. Heart transplantation has evolved in the treatment of choice for many people with advanced heart failure who have severe symptoms despite maximum medical therapy. The number of heart donors has reached a plateau worldwide. We are performing worldwide more than 5,000 cardiac transplants, while 50,000 people who are eligible on the waiting list for heart transplant. So the VAD, ventricular assist device implantation in patients with congestive heart failure, has excellent outcome when compared to medical therapy. It has become an important option for the treatment for the patient with advanced heart failure. Nowadays, the number of VADs exceeds the number of heart transplants worldwide. Do we need a VAD program? We ask ourselves in Saudi Arabia at our institute. So do we need to introduce a VAD program? So when we found that our population now in Saudi Arabia exceed 33 million, around 500,000 of the population that are living with heart failure. 53,000 patients develop heart failure annually. And this is the latest publication from our Saudi Center for Organ Transplantation, which is released late 2015. We don't have yet an updated data. So 500 patients who are on the waiting list for heart transplantation in Saudi Arabia. We around 100 donations each year. Only 51 hearts were non-suitable and 40 hearts were taken. So around 50% of the donation were taken. But only 6% from the waiting list who have been performed heart transplantation for them. And 17 their valves were taken. So definitely we need to introduce the VAD program to cover the deficit. But it is profitable, so the program might not be cost effective in the beginning due to infrastructure costs. But however, the VAD program will cause a halo effect in the institute, so which increase the overall procedure done in the center. Not all the heart failure patients referred for VAD assessment, they will receive, who will have a VAD, but they will undergo many investigation, percutaneous intervention, surgery, or electrophysiology procedures at the center, so on so they will increase the revenue indirectly. So this is cost justification. As I mentioned, we do have a structured program at our center consisting of cardiologist, cardiac surgeon, and it's a multidisciplinary team. Covered every aspects related to that patient. The infrastructure all related to the patient and the family and the caregiver. And the cornerstone of this program is the VAD coordinator who coordinates between this multidisciplinary team. So we speak about our program in Prince Sultan. We settle a vision is to be a nationally and internationally recognized innovator for mechanical assist device. Our mission is to offering a diverse range of security support for our patient. We do have a structure. It's about it's reported to the chief of surgery and medical director, and we have quality officers and patient safety and coordinators. So our main indication in the center is for bridge to recovery or destination therapy. Very few patients bridge to transplant who were referred to Riyadh, because not yet we perform transplant at our center. Our inclusion criteria for the VAD, Intermax category from 1 to 7, with NIA class 3 to 4, with no contraindication to anticoagulation, and absence of active sepsis or risk factor of sepsis, with medical treatment at least, failure of medical treatment at least 60 days, with 1 admission in the CCU. We exclude the patient less than 18 years at our center, or patient who referred from another to another hospital for acute care hospital, or patient who left against medical advice. For the meantime, ischemic cardiopathy we are not included in our criteria, but soon we will start to include them. We start our program in May 2017, up to date November 2019. 64 patients were referred to our program. 7 they were non-fit, 18 refused, so we faced a lot of refusal. 5 patients referred to our colleague in Riyadh and King Faisal to perform heart transplantation. 6 is still under review our team. This is up-to-date information, and 2 died while thinking. Among the 64 whom they were referred to our program, we performed 26 patients. So their profile, their mean age 44 years, all of them were male, with NIA class 4. 5 of them, they were labeled Intermax 4. 12 of them, they were labeled Intermax 3, and 9 of them were labeled Intermax 2. Their mean ejection fraction pre-LVAD 16%, with mean duration of medical treatment prior to the LVAD 20 months. And this is one of our patients, X-ratio cardiomegaly, and the echo shows severe MR, and I don't know it. Anyhow, the echo is showing severe LV dysfunction with ejection fraction less than 20 with severe MR. It was working before. Maybe loading, just a minute. Anyhow, it doesn't, it's okay. So our surgical implantation, we used HeartMate 3 for the whole 26 patients. We performed the procedure on beating heart on cardiopulmonary bypass, but without introducing cardioplegia. Our mean bypass time 53 minutes. with mean operative time around 4 hours. And this is a short video of the procedure. The head of the patient is down and the foot is up. So we are installing first the cardiopulmonary bypass and the ascending aorta and in the right atrium. Then we are preparing the inflow cannula in the apex of the left ventricle. There is many technique to implant LVAD. Some people, they are doing coring of the LV before and some before, but we are reducing the time of bypass. We are doing everything before. And then now after fixing the ring in the apex of the left ventricle with the interrupted suture, now we are coring with Trendelenburg. We keep the patient in Trendelenburg position so that we cannot, we avoid any air embolism with bypass on full flow. Then we core the LV, and of course the apical part from the left ventricle will be sent to biopsy. As I mentioned, the procedure done on beating heart, and then we prepare our LVAD. After the airing maneuver, we fix the LVAD and the LV in the apex of the left ventricle, and then we are passing the drive line, which will connect with the power and electrical supply for the machine. And then now we will perform the proximal anastomosis on the ascending aorta using 40 prolin. This is one of the most important steps in the procedure, is to measure the distance and the alignment of the graft so that we avoid kinking, and of course the de-airing procedure is crucial here. There is many surgeon implant with using sternotomy or thoracotomy, it's depend. But we do prefer do sternotomy, it's more safe. And then we wean from my bypass immediately after the de-airing. And this is the alignment of the graft, it's not kinked. And I'll start to, then this is very crucial. This is the TE intraoperative. The site of the cannulation is very important. It should be toward the mitral valve, between the septum and the free wall of the left ventricle. Otherwise, we will suffer later on from many troubleshooting as suction event and reduce of flow. Okay, I think there's problem in the videos here. So the hospital course, our, as I mentioned, the hospital stay was monitored by that team, and the mean ICU stay 7 days, with mean hospital stay 21 days. And this is the discharge. We have a dedicated home team who taking care of discharging the patient and follow up the patient the first week. Then our regulation and the protocols and out for follow-up, our mean follow-up till now is 20 months. We do have 2 patients who developed stroke and hemorrhagical stroke. We don't have thrombosis. 2 bump replacement, we did not replace any bump. And we have some patients with driveline infection, but the superficial is not deep. So we do each visit physical exam, and we review all that parameter, driveline exit site care, which is very important during the follow-up. And our target INR is from 2 to 3, with follow-up ecography and chest X-ray and routine lab, and evaluation by multidisciplinary VAD team each month. And this is one of the follow-up, the echo, showing there is no turbulence around the cannula, the inflow cannula. And we can see now how the size of the heart is reduced in compared to the first X-ray. And this is one of the community outreach activity during one of the patient family educational session. And this is, we do have regular social activity with the patient, barbecues, meetings and gathering, and this is how they return back to life, resuming full social activity, even though they traveled abroad, the Kingdom of Saudi Arabia. One of them, he traveled to USA, and the other traveled to Canada and Australia. We do have patient. We are proud to help this patient. This is one of our Egyptian patients. We did him in emergency. He was Intermax 2, and then after performing of the LVAD 2 to 3 months, he left home here in Egypt, and he is following, I think, in Al-Azhar University, and sometimes with the clinic belong to Aswan Heart Institute. So we do follow certain indicators to assist our VAD program. One of them is the LDH. We have 0 patients who developed hemolysis, and the other one is the patient whom return back to full social activity and return back to, so 96% of them, they return back to their social activity, and the patient home visit were prepared and done pre-op for them, 99%, because some of the patients were emergency, we don't have time to perform it. And then the number of driveline infection, the superficial, up to this one, and the latest thing, as I mentioned, we do have 2 patients who develop intracranial hemorrhage, one 8-month pre-op and one 4th month, 8-month post-op, and the other one 4th month post-op, and they died. This is some of our accreditation in the center. This is the GCI, and this is the certificate from distinction from GCI for specific, this is CCBC, certificate specific for program, clinical program. Well, this is for acute MI, the other one is for heart failure, and the other one is for ventricular assist device. All those accreditation, we are proudly the only center outside United States who will be accredited with those clinical specific disease for heart failure, MI together, and VAD. And this is our national Saudi accreditation, and this is one of the distinguished accreditation in the center, which is related to medical travel patients. So our center is registered at Euromax, so all our data are published there, and with full transparent access. We do have some of our patients whom develop recovery. 5 of them showed on the follow-up myocardial recovery. So we follow up certain protocols to assist the recovery. We go down with the pump speed from, they were fixed ranging from 5,200 up to 6,000. So we downing the pump speed up to 3,000 with the specific anticoagulation protocols. Then we assess them without LVAD for 30-minute echography, and next session for invasive hemodynamics. The mean support time of LVAD were 562 days. You can see this is their echo pre-implantation, which is less than 20%. This on LVAD post-op. During the LVAD support. Okay. Now we have to see just 2 minutes. Okay, just a minute, please. Thank you. Okay. So as I mentioned, this is on LVAD support, and this is during the recovery assessment. We wean the LVAD completely, and then on the pump speed 0, and this is how we improve an ejection fraction. So we decide to wean and take out and deactivate the LVAD by a novel technique, which is, according to our knowledge, not yet done worldwide. As we are not removing the LVAD, we wean the LVAD and we keep the LVAD inside the patient. And so now this one, post deactivation, so their ejection fraction above 40%. So our way is a percutaneous closure of the outflow graft using the blaster vascular plug through the outflow graft through the ascending aorta. We are introducing through the femoral artery and then descending aorta and go back through the outflow graft. Yeah. So this is the LVAD, the HeartMate 3, and this is our catheter inside the outflow graft showing the flow. And then we close the outflow graft through the blaster. We are using 2 blasters. And then under fluoroscopy, we determine the axis of the drive line, subexploit incision small 2 centimeter. We cut the drive line, we remove from the exit side. And then we extubate the patient in the cath lab. And this is the procedure. So now we are deploying the blaster distally and proximally in the outflow graft. So as I mentioned, their profile post deactivation of the LVAD, they were 5 patients. Their mean age 38 years. All of them were male with mean LVAD support time 562 days. And their mean hospital stay post deactivation of the LVAD were 7 days. With mean post activation now follow up around 100, so almost 4 months. With mean ejection fraction 40 and their survival 100%. This is one of our activity which we performed last year. We conduct international congress.
1 minute, please.
Yes, it's before that. This congress was held in Al-Hassa in conjoint with the first international congress of mechanical cycle support between Prince Sultan and Salbetria from Paris, and also with the Cleveland Clinic, Ohio. So we have an international distinguished guest also from worldwide, including some figures of cardiac surgeon from Egypt. We did first creative workshop on cows, animals for LVAD implantation. And then we have been honored and to receive and host a Cleveland Clinic Ohio team to assist our hospital, and we are in continuous collaboration with them for healthcare service. In conclusion, LVAD has been proven performance and efficacy for the management of end-stage heart failure. It improves quality of life and helps myocardial recovery. And there is no difference between LVAD and heart transplant with regards of late mortality in the first 2 to 3 years. Thank you very much for your attention.
Okay.